Oh, great. Oh, great. Just wondering. So it's on this laptop. Yes. How are you? Just timing. This presentation.
So I've got it set up right now, so it's seeing downstairs. But what we could do is, do you know who? Is there any way we sit next to Jim?
Not right now. I would be the person if he needs it.
Okay.
Or we can just send nobody.
Well, as long as he knows how to do it, then it's.
I'm just.
Okay. All right, if you're a member of the commission, we're going to sit up here. If you could make your way to your seats, we'll get started in just a second. All right, we're going to go ahead and get started. So we'll call the meeting to order. Let me first just say thank you to the commission and its members. We have quite a few people joining us by Zoom today that were not able to be here in person for various reasons. But we had a great year in 2022, and this commission and the members of this commission and our subcommittee chairs and all those members have worked extremely hard for the last 2.5 years now. And we appreciate the speaker, appreciate Mary Margaret Oliver and Representative Todd Jones shepherding this bill through the Georgia House of Representatives. It was a bill that this commission had so much influence and input on. So it was 2022 was the year of mental health reform. I know NAMI tagged that line early, and appreciate NAMI. Appreciate all the think about all the folks who surrounded us on the commission, and from the substance abuse folks, the mental health community, the advocacy community, everyone came together and we accomplished some big things. But our work's just getting started. The commission has a lot of work to do. So now we're going to make this the decade of mental health reform. So we're excited to continue our work. But I think that before we get started, we will introduce them. We'll let everyone introduce themselves. And then if we have access to the people on Zoom, will it be possible for them to introduce themselves also? So we'll start. And if you don't care, when you get ready to be introduced, just give me the number that corresponds with the microphone in front of you, and that will allow me to turn you on.
Good afternoon. I'm Mary Margaret Oliver. I'm a member of the commission and happy to be here today. Thank you. I represent House District 82 in DeKalb County.
All right, thank you.
Good afternoon. I'm Dr. Brenda Fitzgerald and a member of the commission. And my subcommittee is Access. And I am so happy to be here. I'm also chair of Resilient Georgia.
Kim Jones, Executive Director of NAMI Georgia, and I sit on Access Committee as well. And Kevin, I can't leave without saying thank you for your leadership. It would not have happened without that. And as mental health advocates, we're so proud and happy to have somebody like you leading the charge.
Good afternoon. I'm Michael Yockelson. I'm the Chief Medical Officer at Shepherd Center, and I also sit on the Access Subcommittee.
Hi, I'm Miriam Shook. I am the educator representative on the commission.
Gary McGibney, I serve on the commission's Child and Adolescent Subcommittee.
Hello, my name is Brian Amaro. I am the Chief Superior Court Judge in the Flint Judicial Circuit, and I'm the Chief Justice appointee to the Commission.
My name is Brenda Weaver, number 11. I'm the Chief Judge of the Appalachian Circuit, and I was appointed by the Speaker.
Number 9. I'm Stan Cooper. I represent Commissioner Ward on the commission, and I also serve on the subcommittee of the Mental Health Courts and Corrections Subcommittee.
Number 8. Good afternoon. I'm Cindy Levi, CEO of Avita Community Partners, and I am a member of the Workforce and System Development Subcommittee, in the Community Service Boards.
Number 7. I'm Gwen Skinner. I'm the Operations Vice President for Devereaux Advanced Behavioral Health. In this past year, I chaired the Workforce and Systems Development Subcommittee, and in the coming year, I'll be on the Child and Adolescent Subcommittee.
All right, thank you. And I'm Kevin Tanner, and I chair the Behavioral Health Reform and Innovation Commission. And then do we have folks on Zoom that want to introduce yourselves? Is there a way to show that?
I'm Eric Lukowitz. I'm a child and adolescent psychiatrist, and I'm the chair of the Child and Adolescent Subcommittee. And I apologize for not being in person. I was exposed by a student on Monday, and I thought I'd save you all from getting sick.
Very kind of you. Thank you.
I'm Mark Johnson. I'm the CEO of Gateway Community Service Board here on the Georgia coast, and the DIO of the Psychiatry Residency Training Program that's in Savannah, and serve on the Access Committee.
I'm Dr. DeJuan White. I'm the Medical Director of the Psychiatric Emergency Service at Grady Memorial Hospital, and I'm on the Involuntary Commitment Subcommittee.
I'm Stephen Kelly, Superior Court Judge in the Brunswick Judicial Circuit, and serve on the Involuntary Commitment Committee.
Good afternoon, everyone. I'm Mike Boggs. I serve as presiding justice of the Georgia Supreme Court. Happy to be on the commission and chair the Mental Health Courts and Corrections Subcommittee.
I'm Bedelia Hargrove, probate court judge in DeKalb County, Georgia. I serve on the Involuntary Commitment Subcommittee. Thank you for having me.
Kathy Goslin. I'm a Superior Court judge in the Northeastern Circuit, and I serve on the Mental Health Courts Committee Subcommittee with Justice Boggs.
I am Sarah Harris. I'm the probate judge of Bibb County, and I serve on the Involuntary Commitment Committee, and I'm also on the AOT Project Advisory Committee for DBHE.
I'm Karen Bailey. I'm a forensic psychologist. I was the former forensic director for DBHDD, retired, and now just a consulting psychologist. I'm on the Involuntary Commitment Subcommittee.
I'm Dr. Sally Coates, a professor of nursing at College. I'm on the Workforce and System Development Committee.
Good afternoon. I'm Sherry Bloodworth, and I'm here representing Commissioner Michael Nell with DCS. Happy to be here.
Did we miss anyone? All right, good.
Yeah, you missed me. I'm Wayne Senfeld. I'm an executive with Tanner Medical Center out in West Georgia. Willowbrook at Tanner is an inpatient facility and an array of services out here in this area. And I sit on the Child and Adolescent Subcommittee as well. Thank you.
Anyone else? All right. Well, thank you all for being with us. As you can see, we've got a large commission and a lot of members participating today. We'll go ahead and get started. We thought that it would be very helpful for the commission because many of you are not necessarily involved in the day-to-day legislative process at the Capitol. You were involved in developing House Bill 1013, but you may not know what the final product was. So I've asked one of the folks that shepherded that through the General Assembly, who's also one of our commission members and will be serving as chair of the Workforce and System Development this year, Representative Mary Margaret Oliver to walk us through the highlights of House Bill 1013. So Chairman Oliver.
Thank you, Mr. Chairman. And I campaigned 2 years ago to get on this commission because of my respect for the way Kevin Tanner drives real work to be accomplished. And so I want to first acknowledge that campaign to get on the commission was successful, and thank Kevin Tanner again for his amazing creation of a legislative engine that created a very significant bill. We all, those of us from the House side of this debate, obviously have to thank Speaker David Ralston also, because his daily support for this effort is very significant. We had 10 hearings. We had over 100 submissions of amendments. I missed Todd Jones today. He was as Speaker Ralston said, his speaker's co-pilots for this legislative effort. He and I got our work plans together with about 7 seconds preparation for each of the 10 hearings. I learned a great deal from him, and I extend my greetings to him today and appreciation for all the endless work that he provided and assisted me in how we managed through this very complicated legislative process. Every time I reread House Bill 1013, I'm again amazed at the depth and scope and the significance of the changes that this bill makes, and specifically the appropriations that goes with this. The Georgia Parity Collaborative prepared for us, and all the commission members have it, a several-page outline of specific dates for implementation of various work, and we're going to be talking about that through this ambitious agenda this afternoon. There's some extra copies of this outline with dates that you may want to take with you, and thank you for the Parity Collaborative for preparing this. Our legislative discussions under David Ralston's leadership began, and it went every day and extended through our final agreement with the Senate for a creation of legislation to enforce parity. Section 1, Part 1 of the bill extends the federal statute that was passed in 2008 and the December 2020 under the Trump administration new provisions of enforcement of parity in specific ways to our Georgia structure. It provides deadlines for the insurance commissioner, who is assigned the duty under the most recent federal legislative enactments, and creates, and this was very much a focus of our legislative debate, backroom negotiations and public discussions about the standards by which the insurance commissioner would decide that parity is being actually implemented in an effective way. The providers, all insurance providers, CMOs, private insurance, Medicaid, all providers covered under these provisions, extending payment for mental health services in a way that is similar to, on parity with, services for physical health. In relation to Part 1, in the specific deadlines we've given the insurance commissioner, and I know he's on our agenda today and he can expand on this. It's also created in a very specific way that was coordinated with the Georgia Office of Hearings and Appeals, a consumer complaint process specifically to assist in having consumers have their issues of parity brought forward. We are very positively engaged throughout all of these discussions. Chairman Tanner and I met with the insurance commissioner and his staff last fall sometime, and we will continue the discussion with Commissioner King in a little bit about the ways in which the federal law assigns him duties, the way in which Part 1 of 1013 specifies deadlines for those duties, and how he is going to meet the obligations of the statute, which are significantly directed to the state insurance. As part of the discussion about Part 1 and the insurance commissioner's duties, emerged an issue that was successfully included in 1013, exactly on page 16, line 368, if you want to make notes, that mandates compliance with MLR. medical loss ratio. Dr. Newton in our legislative discussions called it medical loss spending. As you know, the federal law requires that CMOs, care management organizations, spend a minimum of 85% of the premiums they receive on direct services. We had some good reasons to believe that Georgia wasn't in fully compliance with that in all of the different ways. And the insertion of mandates to comply with MLR and give specific reporting on that compliance by each CMO and not aggregates or non-averages, I think was a very helpful addition to the bill. And I'm very pleased that it is in there. Section 2 deals with workforce and system development, and I'll be chairing that subcommittee going forward. The provision of in excess of about $10.2 million towards cancelable education loans for mental health provisions obviously gives direct opportunities to enhance the workforce in underserved areas. We extended the opportunity to cancel loans for primary care medical students and for psychiatry students. That's an extension for the medical providers. But the extension to a variety of additional mental health providers set forth on page 31, line 767, to psychiatrists, psychologists, professional counsel, social worker, marriage and family therapist, clinical nurse specialist in psychiatric mental health, or other licensed mental or health behavioral clinicians or specialists. That expansion of that list of professionals that may have an opportunity to have their mental health degree education attainment canceled is a very important part of workforce development, which we all know is an issue facing every single one of our state agencies, not to mention our private. The workforce database set forth in section 2.2 directing the licensing board to create a behavioral health care workforce database is an essential need that we have right now, combined with our workforce development cancelable loans, to figure out where the service providers are and what kind of work they do. This behavioral health database requires them in the workforce development board, Georgia Composite Medical Board, as well as the other Georgia Board of Nurses and Georgia Composite Medical Board and the board examiners of psychologists and several others, to develop specific information in this database. What kind of practice do they have? What is their service deliver area? Do they take Medicaid? Are they expecting retirement? What percentage of their practice time is actually spent on direct services? This development of a behavioral health database will go hand in hand with us extending the opportunities for people to be served in underserved areas across Georgia. Part 3 dealt with involuntary commitment and specifically set forth all of the language of the assisted outpatient treatment program, a program that is now in a pilot form under the Commission on Behavioral Health and Developmental Disability, but is also creates under Part 3 of the bill, beginning on page 35, an opportunity for 5 specific grants to be extended to throughout Georgia to create this program for folks that have been in a serious psychological psychiatric crisis or coming out of either a mental health crisis center or out of a jail, to create an outpatient treatment program with supervision and services. The AOT program has been a very important part of the work of Justice Boggs and Judge Amero's work. We worked with them continuously through the session, and we are very pleased that the AOT program, with its funding and with its 5 pilot programs, is in the bill. The bids or the post of an opportunity for a grant has to be done by October and has to be awarded by December. So we are going to have a good opportunity, hopefully in a diverse set areas of Georgia, to see how this outpatient assisted treatment program works. over many times in my career, we have looked at the mandatory outpatient treatment statute, which is never used. I've tried to use it myself in probate court unsuccessfully. This assisted outpatient treatment program and design is, in essence, a real way to try to figure out if outpatient treatment can be effective to stop the coming in and out of ER rooms, coming in and out of jails, and coming in and out of crisis centers that we know is a very significant problem for the severely mentally ill person. If we could solve the problem of the circling regular customer for either children's ER or with the adults in the assisted outpatient treatment program, we will make real progress. And I look forward to seeing how those grants are awarded this coming December, and following the analysis and data that I know Judge Amero and Justice Boggs will be collecting to help us improve our outpatient treatment service for what we call the usual customers of intense mental health services. Section 3.3 deals with the opportunity for a police officer to take someone into custody by virtue of not seeing a felony committed, but instead seeing, having an opportunity in the field to communicate with, have perhaps a video, but have a consultation by some technology with a physician or a qualified person to make an assessment to whether or not this person needs to be taken into 1013. The only substantive position we did not move forward of all of the provisions that came out of the commission was the standard by which 1013 could be implemented and used. And I was accepting of that decision not to move forward with 1013, not to remove the word imminent, if you remember that debate, and to go forward with this alternative suggestion. I think that whether or not Georgia's standard of imminent harm to self or others, which is only set forth in statute, that word imminent in about 16 different states, that's an ongoing discussion. I think we'll come back to it. But of all of the amendments, I would say at least half or more of the amendments that were suggested to us through our 10 hearings and in our negotiations with the Senate, the removal of the decision to take the word imminent out of the 1013 process is the only significant substantive matter that we did not move forward with. All of the other provisions of the bill as introduced were carried forward in maybe alternative ways, in a variety of ways, and in ways that I think improved the bill as we went forward through the process. When we move over to Part 4, we are granting to a variety of different ways the Criminal Justice Coordinating Council. I'm glad to see Jay Neal here today to give him specific authority on certain funding opportunities, on accountability courts, and to give him certain additional funding, particularly in relation to providing transport services. Those of you that followed us in the Capitol know that the transportation services was a recurring discussion in almost every one of the hearings. And we have done a number of things, including CJCC, to extend the opportunity to have some funding, to have some surveys done. How exactly are transports being handled across Georgia? We had a lot of conflicting information about that in our hearings. Grant Thomas, under the Governor's Health Coordination Council, is also tasked in the bill, later in the bill, and he has already begun the task that we gave him in this bill to do an analysis of transport services. It was an important issue that created a law about a discussion. We also gave specific authority and this is something that we did in Section 4.3, we gave some new duties to the Office of Health Strategy and Coordination. That is, again, the Grant Thomas. We found that there are a number of different agencies that were in our review of all of our statutes that gave the same duties to multiple agencies. In order to try to streamline that, and this is one example, we did give more specific authority to what I call the Grant Thomas Council, and specifically gave him the obligation to create a uniform formulary for mental health substance disorder for prescription use. And he has a deadline. I reminded him every time I see him that his deadline is December 1st, 2022. That's a duty that was assigned to 3 different agencies historically. Now it is located directly with that Office of the Governor. And I know that he has begun work on that. And I know that he is reaching out to get specific assistance on that. And again, as I said, he has given a new duty in relation to developing transport analysis and surveys, and he has to give us that report on what exists out there by January 1st, 2023. Section 4.4, we picked up 2 bills that were introduced by Jasmine Neal of the House in relation to training under co-responder programs. In general, Senate Bill 403, authored by Dr. Ben Watson from Savannah, was passed independently. There was initially a great deal of overlap between 1013 co-responder programs and Senator Watson's bill of co-responders. And we made an agreement with the Senate that his bill 403 would go forward. But the coordination of all of the references to funding and to evaluation and to grants, and specifically how the co-responder programs will be funded through the CSB or any other private provider, is another big step of new services provided. In my district alone, 2 of my cities, Decatur and Brookhaven. Brookhaven has already implemented for a good while the co-responder programs where mental health professionals go out with law enforcement, and Decatur is negotiating now with our CSB. That's a very, very positive step that I'm seeing in between 15 to 20 perhaps areas of Georgia, just initially stepping forward to make that part of their law enforcement delivery. On page 72, under 6.2, this is a way to try to, again, to coordinate multiple tasks across multiple agencies. New duties have been given to this council, the Department of Behavioral Health and Developmental Disability, in terms of what I call the Kevin Tanner Commission. We will be taking on some new responsibilities, and I think a lot of our agenda today deals with how we are going to implement those new responsibilities, either the new responsibilities for this commission or the new responsibilities that are created by the Grant Thomas Commission under the governor's office. Every time in our original bill that we set out a task force or an advisory committee or additional commission, we looked at all of those comprehensively because they came again from different subcommittees. And in an effort to engage other professionals, engage other stakeholders, those are mechanisms that are frequently used. But we have to be more thoughtful and more strategic on what commission or what task force we are really assigning the duty and giving them a deadline. And in several places, as I've mentioned, we've done that on 1013. There still are though, multiple assignments of duties. And as we go forward with implementation and our next step, one of the things that I'm looking at is what did we do to accomplish a streamlining of duty and responsibility and deadline in what is still out there. So there is a great deal of work to do. I'm very, very pleased to be a part of this discussion. And again, I say every time, it's really a privilege to work on real work, real legislative work that's going to have a specific, dramatic, I think, opportunity to serve Georgians who are in need of mental health services. Thank you, Mr. Chair.
Are there any questions of Chairwoman Oliver? As you can see, this is a very comprehensive piece of legislation, but it's a result of a lot of comprehensive work, but couldn't have been done without the work of Representative Jones and Representative Oliver in the House and staying with it through the Senate. They did a tremendous job. I gave a shout out to our advocacy community in the beginning, but we had one walk in. Our probably most famous advocate on social media is Jeff Breedlove, and he did a tremendous job. And I will give him a shout out, Georgia Substance Abuse Council, with building just support and grassroots support and talking and speaking highly of reps and senators. So appreciate what he did and continues to do along with all of our advocacy community and really building I called it a steamroller. You're going to get, it's a freight train, you'll get run over if you get in the way. That's the type of mentality I think that we were able to build. So thank you. One of the things that's not on the agenda that I had asked Dr. Fitzgerald if we could have a little opening presentation, but wanted to cover the bill first. But I'm going to let her introduce our opening presentation from Children's Healthcare.
One of the most important things we heard in a lot of testimony had to do with, we were talking about people revolving throughout the system, in and out of the system. And we have Dr. Dan Salinas is going to give us some information. He's with CHOA, Children's Healthcare of Atlanta, and they were very instrumental in collecting a lot of data for us. And we thank you for being here to present to us.
Thank you, Brenda, and Chairman Tanner, members of the commission. Thank you for having me today. I would like to reiterate just a couple of things that were said earlier. One is to thank you all. As I looked at House Bill 1013 as it was being formulated, it was clear that the work of this commission was being incorporated, which is just phenomenal. And Chairman Oliver, I want to thank you for mentioning the children's emergency rooms as it's part of this area that needs care coordination. What I want to do today is focus my comments showing you some data that we collected that some of you already saw. We presented it as part of the Mental Health Parity Act bill process, but I think it's important to see it and then to reiterate why it's so important to have the care coordination component of this bill. I do also remain very optimistic that as a result of House Bill 1013, that Georgia's going to have one of the best infrastructures, I think, in the country. Will there be slides up? Okay. Let's see. No, that's not it. I don't see it on the screen. Nope, I didn't bring flash.
Okay, you send it to Chelsea.
Yeah.
Okay, let me.
But I'm willing to go ahead. Do you want me to go ahead and start? I'm happy to do that and share this data with you. So what we did in 2021 as a part of our own understanding of the issue with children with recurrent admissions to our emergency room is we looked at a cohort of patients in 2020. It was about 68 patients. We looked at patients in 2020 that had 4 or more emergency room visits to Children's Healthcare of Atlanta. And we found some pretty astounding statistics. So out of this 68 patients, they comprised 392, so almost 400 emergency room visits over that year. 38 of them, or 56% of them, after they had left the children's ER, came back within 7 days. And 88%, and you'll see why in just a minute, 88% of these children and adolescents that were discharged from children's were discharged to a psychiatric facility at least once. And when they were in our emergency rooms, the average length of stay was about 10 hours compared to a regular child in the ER, it's about 2.5 hours. So about 4 times almost the amount of time, 4 times actually, the amount of time that children normally spend in our emergency department. I want to share with you the profile of some of these kids because I think it tells a big story. The male-female ratio was almost 50-50. It's about 46% male, 54% female, and the average age was about 13 and a half years of age. When you look at the array of issues that these children bring with their mental illness, at the core of all of their issues was trauma. It's either sexual abuse or physical abuse. But let me share with you, 19% of the kids were runaways, 16% had been abused sexually, 70% had a history of violence, 37% physical abuse, 33% had been in a foster or group home, 66% of these kids, of this cohort of 68 kids, had been in DFACS custody. And you'll see in a minute, I'm going to share some other data with you. 64% presented with self-injury, 78% presented with suicidal ideations, so attempted death by suicide. And 94% of these kids had one or more mental health conditions. So there's no surprise that in this cohort of 68 kids that we saw children with so many visits to the emergency room. Okay, thank you.
The pressure to remember your password when a room full of people is watching.
I'm just impressed you didn't have to look it up.
Oh, you watched that, right?
Oh, no.
May I ask a question while
Yes,
we're
yes.
waiting on this important duty? I have different opinions come to me about whether or not we have a shortage of beds for children in Georgia versus simply a shortage of coordination and use of beds for Georgia children. We know that so many of our beds are taken by other states based on our very low reimbursement rate. What is your opinion about that question? Do we have enough psychiatric beds for children in Georgia? Because CHOA doesn't offer beds.
So a very good question. So the question is, do we have enough psychiatric beds? In general, the answer is yes. But part of that answer is it depends on any given day, the given child, their presentation, their condition, et cetera. And then now, so if you had asked me that question a year and a half ago, I would have said, yes, plenty of beds. Now there can be plenty of beds, but they may not be staffed, because just like at Children's Healthcare of Atlanta, the mental health facilities now are challenged with staffing issues. So it's a both and, Chairman Oliver. But we have really good, strong partnerships with the hospitals in Georgia, and in general are able to place children. We do have some struggles at times, but we have very strong partnerships because of our track record and then the work that we do with them after kids get placed there.
Thank you.
Ms. Skinner.
I think Representative Oliver and I have talked some about the bed space issues in Georgia, and certainly we know that some of our beds in our psychiatric residential treatment facilities are filled with children from out of state. I think it depends when you talk about beds, it depends on which beds you're talking about.
Right.
If you're talking about the psychiatric residential longer-term care treatment facilities, do we have enough beds? Do we have enough beds in crisis stabilization units? And so I think it's very hard to give an answer about, do we have enough beds, without the context of what kind of beds are we talking about, and having a good handle on the demand for which type of bed.
Yeah, I think that's fair, Gwen. And I didn't bring this data, but I can show you that over the last 18 months, the number of kids presenting to children's ERs in crisis with a primary mental and behavioral health condition has started to really, really go up.
Right.
And those that we have to place under 1013 confinement or commitment has gone up dramatically. So the issue is not getting any easier right now.
Right.
And it's a combination, I think, of COVID, of social media, of the status of families, it's a combination of a lot of different things. So
I agree.
but thank you for that. There was a piece I wanted to show you on this slide that I didn't mention, and that is the mix of the kids in that 68 patient cohort. The majority are traditional Medicaid and a Mary group. And then our data shows that the ones in a Mary group are the ones in foster care. So you can see the predominance of those two payer sources for these kids that presented to us. Move forward here. Let's see if I can get this. Okay.
While you're going to the next slide, just to emphasize that point, those folks you're talking about are the ones that fall under the state care in some way, our state insurance.
Yes.
So we have much greater control over what we provide or don't provide in those areas. And that's the majority. What was the percentage you said of those patients?
Of the kids that are in it was almost 90% of the kids in this cohort either had traditional Medicaid or a Mary group.
Okay.
As their payer source. It was close to 90 with the numbers. This was the slide where I was showing you the profile of these high utilizers. And I wanted to just share with you some of the key takeaways here with this cohort of kids, because this really will emphasize to you why it's so important that the component of House Bill 1013 that this commission has been tasked with, that is continuing to improve care coordination, is really so critical. So as I mentioned, each of these children had more than one behavioral or mental health comorbidity. And then no surprise, because it follows, some of the kids also had, a large percentage also had a chronic illness like asthma or something else, and that's not uncommon. Each of these kids had at least 10 psychiatric hospitalizations. And what is the most astounding is that every hospitalization is almost like it occurred in a silo. So when they go to the next hospital, there is no way for that next hospital to know that that child was in a previous hospital. There may be, depending upon what the parents know, there may be a way to know what medicines they're on, but that's not necessarily true. As you know, Gwen, they show up with a bag of medicine and it's left where you all are left to figure out what's there. So if there's any reason to emphasize the importance of care coordination, this is one of the biggest, but so is this third one. Most of the patients reported having some type of outpatient service, therapy, med management, some type of treatment in their community. Yet, once again, at any given moment, the coordination of that treatment and the ability to know who's being treated by what, and for the pediatrician to know that a child is being treated by this agency or that agency, it doesn't really exist in a really robust form right now, but I think that it will. A lot of the children had been not only in DFACS custody, but also in DJJ custody in part of their journey. Several of the patients had multiple documented payer sources. So over this 1 year period of time, they may have been in 3 different care management organizations, for example, in Medicaid, or moving from one to the other. That speaks to the importance of care coordination, but also into the importance of the unified formulary, which is also a provision in the bill. And then, as I mentioned, most of the patients had significant trauma, physical and sexual abuse especially. So this big opportunity to improve care, at the core of it lies in the development of the care coordination function that you all have been tasked with. And what I wanted to offer out to you is that Children's can be a resource to you all. We can provide some expertise. I'd love to get the right group of people to sit down with the right people in the commission, Chairman Tanner, and sit down and talk about what your vision is for this piece of the work and what we might be able to do to help you.
Well, and we want to thank your CEO, Donna. She serves on our subcommittee for access and has been very intimately involved in this process. So we appreciate CHOA's partnership. One of the things that you hit on that I think is important, and I think we're going to hear about this from the Accenture report here soon, and also from our goals, is the lack of information sharing, both within our agencies at the state level and the siloing effect you spoke about. But also just in the care management, it's an issue. And I know, again, not jumping ahead, but when the governor tasked Accenture to do a report, a couple of the big items they found centered around that. So that's something we're going to discuss later in the meeting. We're going to discuss some goals for this year But one of the big ones is finding a way to solve that riddle and make sure that information is able to be shared.
Thank you.
May I ask a question?
And one thing I want to say, we are having at the very next Access Committee, which is June 23rd, so in a couple of Thursdays, and it's between 1:30 and 3. And of course, you can Zoom it, is we're going to hear from the pediatricians from the hospitals, from AmeriGroup, discussing this whole business of how the communication is occurring between hospitalizations. So I want to make sure and invite everyone to hear, to listen into to those presentations.
I'll leave you with just one thought, if I may. And it's an adage I heard years ago, and it's that systems produce what they're designed to produce. And I think what we are at is at the precipice of an opportunity to really create a system, an infrastructure, an entire system of care for the state that can produce better and different results than we've had today. And I really appreciate the work that you all have done, and we're willing to continue to help. So thank you.
May I ask a quick question, Dr. Salinas?
Yep.
Did the numbers that you
Do patient
represented?
care coordination for physical health?
Yes. Oh, goodness, yes. Every child with physical health on the payer side has a care coordinator. Now they have to meet a threshold. So you can imagine a child with cancer, for example, they have it. So you've hit on something very important.
As an advocacy organization, we see this not doing it for children with mental health as discrimination.
Agreed.
My daughter, youngest daughter, has to go to the Mayo Clinic in Minnesota for a health issue, and it is amazing at the coordinated care. She can go in and get there at 9 o'clock and see an orthopedic, a neurologist, pain doctors, physical therapist, all by 2, and have all the tests she needs by 2. The next day, she can go back and get all the results and meet with all the doctors at one time and get all of her results and her treatment plan. It's just absolutely incredible when you bring all the right people together in the same room and they're talking to each other.
Yes.
Kim and I had the opportunity to go to Mercy Care in Atlanta, tour their facility. They're doing great work there at that facility with coordinated care, dental, psychological, physical health, all under one roof for the indigent here in Atlanta. So great job they're doing. So any other questions? Thank you very much.
Thank you. You're welcome.
We're going to check and see if we have some questions on Zoom. Are there any questions from our members joining us by Zoom?
I had a question specifically for Dr. Salinas, if he's still there. I wanted to know if the numbers that he showed us included patients with developmental disabilities and autism, because it's been my perspective that while there may be an adequate number of beds overall, when it comes to the number of facilities accepting patients with developmental disabilities and autism, that those are severely restricted. And sometimes that ends up with patients languishing in emergency rooms for days and maybe even weeks.
Yes, I agree 100%. When I mentioned that there were some children that had very specific conditions that could lead to even longer lengths of stay in the emergency department, it is exactly the ones that you've mentioned. There are good facilities for kids with autism. The most difficult child to place is a child with autism, with intellectual disability, maybe with a severe language delay, with aggression. It's very difficult, and it's gotten more difficult now because many of those kids need one-on-one care, and that is hard to find right now in the facilities because they're so staffing challenged. So thank you for pointing that out.
Any other questions from our Zoom members?
So just wanted to provide some context. When you look at those numbers and things like that, it's really important to keep in mind that, if CHOA had their own inpatient child psychiatry unit, those numbers would look better. And so I just think it's important to remember that that's a system that chooses not to provide inpatient mental health care for children, and that chooses not to provide outpatient mental health services for children. And if major hospital players like CHOA stepped up, this problem would not be as pronounced. And I just think it's important to keep that in mind as we discuss these things. The other thing that I wanted to add is that, yes, there are coordination issues, but there are very real service issues as well, not just for children who are publicly insured, but for those who are privately insured too, where you have problems like provider panels being full, people not taking new patients, those workforce issues showing up. So I don't want to paint this as purely coordination. There is absolutely a tremendous service gap as well.
Thank you. And that was Dr. Sarah Vincent. If you're on Zoom, we are not able to see you when you speak. So just introduce yourself to us when you ask a question or make comments, just so we'll know. But it's Dr. Sarah Vincent. Thank you.
Sarah, thanks for that, for the comment. I would like to respond to just a couple of things. We have right now the first of many years of a mental health strategy, $170 million over 5 years. Part of that strategy, part of this first part of that strategy, we have built an outpatient referral center. Right now, this first one is only receiving referrals from inside of Children's, and it is staffed with psychiatrists, psychologists, LCSWs, et cetera. We have also built a pilot integrated mental health clinic at Hugh Spalding, where we have a primary care clinic. And this is a pilot, but we know that this model of integrated mental health care is really the way to go. And that pilot is staffed. So the pediatricians at Hugh Spalding work side by side with a psychologist and a licensed clinical social worker to deliver immediate warm handoff care to kids with that present to the Hugh Spalding primary care clinic with mental health concerns. So we're on our way. So thank you.
All right, thank you. All right, next up on the agenda is review items assigned to the commission. I just wanted to talk through a few of these just to make sure that the members of the commission were aware of them. I had conversations with some of our subcommittee members about and chairs about this. Starting on lines 1429, it talks about some assignments to the Mental Health Courts and Corrections Subcommittee. Representative Oliver shared with you there were several things tasked to the commission and to other departments throughout state government. Here it talks specifically about some items for the courts, expanding access to mental health specialized caseloads to reach a broader audience, including prioritizing equitable access to specialized caseloads. So I know that Justice Boggs and the Access Subcommittee are both working on that, along with number 2, which talks about accessing the quality of mental health supervision and adherence to evidence-based standards to determine how mental health supervision could be improved by identifying services and supports that would equip law enforcement officers to be more successful engaging and reducing recidivism for individuals on community supervision. That was a big topic of conversation. It's not, the answers to those questions are not easy, but it's something that they're going to be working on this year as one of our goals. Another one's accessing the availability of mental health treatment providers by supervision region to estimate the accessibility to treatment across the state. We know that we heard over and over again, access is not the same in every part of the state. Depending on where you live, the Community Service Board may provide a certain level of access or may not. Other providers may provide that. Not everyone has CHOA or even a hospital setting. So we're cognitive of that. And I know from a corrections perspective and people who are on supervision, that's an important thing that Justice Boggs is working on and Judge Amaro. And then over on page 7 or line 1759, if you're making notes in the bill, this area specifically goes into, again, some other items around the courts. Specifically, one of the things that Justice Boggs has already done is there was some conversation during the session about familiar faces. You heard Choa talk about seeing the same patients over and over. We know that most of the folks who are accessing the criminal justice system, we're seeing them repeatedly over and over and over, familiar faces. And that's something that's had some success around the country of identifying and putting specific treatment and specific wraparound services in place. So Justice Boggs has created a specialized subcommittee of his courts and corrections and brought in some outside experts to deal with that conversation. The commission and House Bill 1013 has been tasked with working on that and bringing back recommendations for policy changes and possibly legislative changes next year. So that's underway. He's already, I know Justice Boggs is on top of that, and that is actually already started. And I believe if they haven't already had their first meeting, I know it's scheduled. Yep, have a meeting already scheduled coming up. So several members that are here today serve on that. So I appreciate the work they're doing in that area. Also serving as a liaison to state and local leaders to inform policy and funding priorities. That's something else tasked to this group and this subcommittee. One of the things too that Justice Boggs and Judge Amaro and the other judges that are working with us, even our law enforcement partners, Sheriff, Police Chief Lou Dekmar said early on, we're really not sure in the criminal justice setting how many people are in jail today that have a serious mental health issue, because our jails are not screening everyone the same way. So there's not a one adopted definition, for instance, of what a serious mental illness is in the screening process. So the commission in House Bill 1013 is tasked with creating that and developing that and working with relevant mental health officials and experts, the judicial and law enforcement officials and other experts in creating that. So I think it's going to be important. And then the second part of that is exploring funding options to implement a universal screening process for admission to county jail and detention facilities. It's difficult to find solutions and to put in corrective measures if we don't know what the problem really is. So it's important. We got to have a baseline. And one of the other things is that they're tasked with looking at adopting recommendations to promote the use of pre-arrest diversion. We know from serving on this commission that we are not interested in people who have serious mental health issues from finding themselves in the criminal justice system. It's not the right place for those individuals. So I appreciate Judge Amaro and his subcommittee and Justice Boggs and his subcommittee really working hard to find alternatives to arrest and alternatives to incarceration. And then also in that same vein, developing a shared definition for what a high utilizer is, so that we'll know again, the population that we're talking about. And then on into the bill around line 1786, improving strategies to refer and connect individuals to needed community-based health and social services. That also includes identifying gaps in community care. So, and then I'll jump down to 1794. This is something that in conversations with Dr. Fitzgerald and also Eric, who may be on Zoom today, but I believe he is, but he's going to be chairing our adolescent subcommittee, and they're going to be working together on starting on line 1794, convening representatives from care management organizations, pediatric primary care physicians, family medicine physicians, pediatric hospitals, pharmacy benefits managers, and other insurers and experts on early childhood mental health and pediatric mental health and substance use disorder care professionals to do a whole host of things that's laid out in the bill dealing with youth in foster care and others receiving mental health services. So a lot of work ahead for our subcommittees that have been laid out in the bill. We tried, and I know Chair Lady Oliver worked hard to identify the things that we knew we needed to do, that we needed more information on, to make sure we included them in the bill to take a step in the right direction. And Representative Oliver.
I have imposed on several of you to help me think through what would be the best opportunity for us to recreate the match committee, which is set out in the bill. I forgot to mention it earlier on page 68, line 1663. There's a recognition that, and it's tied in part to the serious discussion right now about the hoteling of children, 30 to 60 children every day. It kind of bounces around our hotels, and the failure to find a placement for those children is a significant focus of our attention. So those of you that may have had experience with the match committee in the previous era and have experience today with the interagency teamwork, I would really like to hear from you as to what do you want the match committee to do? And how do you want it to operate in an independent way to coordinate the services that might be available? I also, Mr. Chair, generated, as you have too, discussions about how we carry forward our duty about the homeless population. And I'm interested in kind of continuing that as a broader discussion about our duty on this council to address issues of homeless and mental illness.
Thank you, Madam Chair. So this takes us into, I want to talk about some of our specific goals for 2022 as a commission. And so that you all as commission members and subcommittee members can be thinking about some of the big picture items that have been laid out before us. One that we received a lot of feedback from during session was around the idea of transportation. Specifically, when someone is picked up by law enforcement or by a family member and taken to a receiving facility, and then they have to have a secondary transport, who's responsible for that? So that Justice Boggs has been working with Grant Thomas and their department, and they've been tasked with doing a study and reporting back to this commission on what that should look like. And specifically, how many are being done, who's doing them, who's doing the secondary transport, and how much that cost the law enforcement agencies involved. Because we've heard from the sheriffs that even if a police department picks that person up, carries them in for, say, a 1013, then the sheriff becomes responsible for those supplement transports later. And they have concerns about that, especially in rural Georgia, where they don't have the resources necessary to provide them. So I know that Grant and his shop are going to be doing a study with a third party and reporting those findings back to us. And hopefully we can come up with some recommendations this year of how to work forward on that. The second thing, it's been mentioned a couple of times, but I think it's very, very important, is the unified formulary. Developing the unified formulary, that's a task again to Grant's shop for what that should look like, but that being adopted either through policy or through legislation and requiring that here in Georgia. Other states have been able to do that. It's a challenge that we hear. I told the story to some of you before of going to Jekyll Island and getting an Uber and telling them I was there to speak on mental health issues, to the caucus, and the lady starting to cry that was driving the car, telling me about her child who suffered from mental health issues. And one of the big issues she was having is the insurance companies kept changing the medication they would pay for. And that's a very, very big challenge for these folks who suffer from mental health issues when their medications are changed. So unified formularies are important. And again, that's something that we want to be able to tackle this year and have that ready to go for next year. The other one we're going to hear more about today, but one of the challenges is data sharing between our state agencies. Those of you who've been around for a while remember when we had DHS and larger agencies, and then we created several different agencies back, I guess, in 2009, maybe timeframe, 2009 to 2012. And as a result of that, we've got great agencies doing great work. They're tasked with certain responsibilities, but oftentimes it's difficult for them to share information between agencies. So one of our goals for 2022 is to recommend how that can be corrected. We have specifically on the adolescent side, there's information that needs to be shared when someone's in foster care, for instance, about maybe their Medicaid or other functions that a different state agency has. And we want to be able to correct that problem. Again, there's some other states that have done some innovative things around this that we're looking at. So that's another goal this year. Representative Oliver hit on the homeless policy. That's also in the legislation. This commission's tasked to look at that. So again, we want to we may not necessarily have the right experts that are members of this commission on some of these topics, but we have the ability to bring those people to the table and again, formulate recommendations around that. We already mentioned the courts. I won't go over that. There's a lot of work around that area in the courts with AOT, additional work there. Judge Amaro has been a champion for that across Georgia and has done great work in that. And we're looking forward to getting those grants awarded and continuing to monitor how we can improve that system here in Georgia. That's worked well in a couple other places that he's worked with. So with that, those are some of our overarching goals for the year. I've had conversations with our subcommittee chairs. I know that many of them already have meetings scheduled. I believe Dr. Fitzgerald has one in 2 weeks. A lot of work left to be done this year, and a lot of studies are being done by DCH, by Grant's office, and by the insurance commissioner and others. So are there any questions, comments, thoughts about some of these overarching goals that we've talked about for 2022? What number are you saying?
7.
Is there going to be a goal related to workforce?
There is, and that's in the overarching plan from the original legislation. But yes, workforce is one of the biggest challenges. As you know, you manage a large facility trying to find we can have all the great policies, but if we don't have the providers in place to provide the service, and Cindy's runs Avita and they service the area where I live. And I know that's one of the biggest challenges facing our community service boards is being able to find providers. So yes, ma'am.
So when I look at these seem to be the goals left over from last year's committee's recommendations. And I know you and I have talked not only about workforce, but also children. So we'll be adding to these based on the committee's work going forward. Is that?
Yes. And these goals that are listed are not all that we need to work on this year. These are the goals that's been listed and talked about in the legislation that we're specifically assigned for 2022 to work on. But yes, the subcommittees are free to go in whatever direction they feel like they need to go in to be able to bring back recommendations for full commission. That's correct. These are just items specifically listed in House Bill 1013. Are there any other questions? If not, we will turn it over to Chris and Haley from Accenture, Chris Young and Haley Cole from Accenture. They were tasked with doing a study by the governor's office and through Grant Thomas's office at OPB last year. And I believe those results were published around the 1st of December. That also was part of what we used in developing House Bill 1013. So at this time, I want to turn it over to them.
Thanks, Mr. Chairman. I'll go ahead. Oh, okay. That was quick. Thanks, Mr. Chairman. Good to see you again. Good to see so many friends. Mary Margaret, I was just sitting there thinking it was 25 years ago that we met, right? I don't know how everyone else got old and we haven't. So Judge Amaro, good to see you too. We're thrilled to be here. We've actually been a part of this process since the very beginning. Haley, from whom you'll hear in a second, embedded with Chairman Tanner during the very beginning of the process of forming this commission and spent some time helping you all put your mechanics together. Several of you came to our offices for a workshop on what each of the subcommittees could look like as we go along. And then we were so thrilled when your report came out and the governor's office asked us, Grant Thomas's office asked us to come in and help be a connective tissue is probably the best way to describe it between the good work you all did and the start of the legislative session. Some of it had to do with sequencing all of your recommendations, making sure that all of them were accounted for in the budget process and the budget that the governor put together and the budget that the speaker put together, so forth and so on. So we did that. We'll share some of those recommendations with you today. You have access to the report, but we're not going to read the church bulletin to you as these slides come up. But what we are going to leave you with, I hope, is a sense of what we heard in particular from the state executive agencies charged with whatever comes out of this commission, both in the past and in the future. My colleague John Kivashi, who in just a second will tell you some of the meetings that we had, the number of interviews, the number of conversations. We spent a lot of time talking with executive agencies charged with what's going to happen now that July 1st has come, and you have other dates that are here as when things are due or when they come online. What will happen? But the big headline out of all of this is there were some very common themes that came out of the discussions with the agencies and the people, the career civil servants with dirt under their fingernails doing this on a daily basis, that said, as the commission or as the governor's office or as the speaker, as anybody else goes forward, here's some connective tissue, here's some things that bind things together. So if you're addressing it, these kinds of things from an administrative point of view need to be addressed. So it'll come clear as we go forward. So I'm going to hush and let Jonky come up, and then Haley will follow her, and I'll be back.
Hi, Commission members. I'm Janki Vashi. Thank you so much for having us today. So here on this slide, I'm kind of covering just an exec summary in numbers of what we did back in October of 2021. So what we did, who we spoke with, and what outcomes we delivered with Grant Thomas's OHSC office. So we interviewed all 5 subcommittee chair members here. We also interviewed 12 agencies related to behavioral and mental health. You'll see all the various acronyms on the board who we spoke with. And this led to us developing an action plan that included 10 prioritized legislative actions, 9 executive orders and agency directives, and 16 budget requests for FY23, totaling a little over 31 million. That's included in the 130 to 180 million that's been appropriated. And we also worked with CSG to develop 9 recommended next steps and considerations for redesigning the mental health ecosystem in Georgia. So how did we do all this? We really took the recommendations of this commission, and to Chris's point, we really just harmonized them, we sequenced them. How do we turn these recommendations into action? So we used and analyzed and researched on the commission's year 1 report. That was kind of like our baseline. We worked with each of the subcommittee chairpersons on terms of clarifications, any additions, modifications to those recommendations. And then we took those recommendations and we went to each of those 12 agencies that are all related to behavioral and mental health, really trying to play a neutral third party in terms of how do we take these recommendations? What are your thoughts? Are these feasible? Who all should be involved? When should these be done? What are the dependencies? And what are the budgets, more importantly, tied to each of these recommendations? And so that helped us to develop this action plan moving forward. So I'm going to pass it to Haley now. I kind of just covered what we did and how we did it over the 2 months last October. So I'm going to pass it to Haley, who won't regurgitate the recommendations. You guys know those recommendations very well, but more so just what are the actions and trends we're seeing moving forward.
Thank you. Good to see everybody. I recognize a lot of faces. Last time I saw some of you in person, we were putting sticky notes of the recommendation on a chart. So glad to see the progress that we've made so far. So really, I'm here to talk about essentially how we want to make sure that the commission has capacity to move forward in solving for some of these items. In some cases, it's items that we can name and specify. A lot of this is what we did for the legislation and legislative period in terms of making specific recommendations. They can be packaged within a year of, we know we need to do this, here's how we can do it, here's whose buy-in we need, that type of thing. So that falls into that short-term category of what we can do for this upcoming legislation. And looking specifically at the budgetary recommendations as well in preparation for that. The next couple of buckets, I'll speak to one and then I'll let Chris have the fun part of talking about the more long-term perspectives. Is looking at some of those recommendations that we understand, but we need to specify a little bit more. So for example, co-responder training, crisis intervention training, we know we need it, there's good buy-in for it, but the hows and the whats and the who's still need to be defined. So making sure that there's capacity to facilitate those conversations and move those forward and alleviate some of the pressure on the commission members from doing some of that work. And the third category is looking more at the long term. So things that we know we need change for, but we don't quite know how to get it yet. So what data quantifies success? Who's capturing that data? Is it accessible to who it needs to be accessible to, excuse me? And is it securely available? So I will turn it over to Chris to talk further about what that will look like.
Thank you. I'll advance. Yeah, because I'm gonna do one quick thing. So Mary Margaret, you said something earlier about being engaged in this process at the very beginning, how rewarding it was. And I keep going back to a phrase they use in Washington that doesn't mean much anymore. It's regular order. And it felt like this was a regular order, right? This was people coming together to solve a gnarly policy issue that affects just about every Georgian, sometimes whether they know it or not, through the goodness of the legislative process, to the input of the community at large, and now with the executive branch and the judicial branch coming together with the legislative branch to figure out how do we execute on those things. And so one of the reasons we're not going through all of the recommendations that were in the report is they made it in the bill, right? And they've already, Representative Oliver covered them in what she said. The chairman talked about them in some of his discourse. So we're not gonna, like I said, I'm not gonna read the church bulletin to you, but what we did find when we had these conversations with executive branch folks, primarily, not only was there a deep and abiding appreciation for what was going on and wanting to be a part of the solution, but, and this is a, or maybe I should say, and they wanted to make sure that once we got to some of the, to use a cliche, lowest hanging fruit that we've dealt with, that there have been issues within the community for a long period of time, that whatever this commission recommends and whatever moves forward in the next year and the next year is long-term and sustainable. That it's not just a legislative solution, a policy solution that does good, but doesn't take it as far as the momentum will allow it to be taken right now within the community. And so as they thought about it, they said, look, there are 4 things, and I apologize if this is small, but you'll have access to this, or you have this. So there are 4 trend lines that came out of it. Number 1 is, and these are in no particular order, these are not ranked, these are just the trend lines that came out. And what I would commend these, particularly to subcommittee chairs, as you begin to think about your policies coming out of your subcommittees in discussion, these are the trend lines. And I don't think any of them will be foreign to you, but they do add a very strong patina of credibility to what you're doing coming out of the executive agencies. Number 1, data. And I think Justice Boggs is on the phone. He and I have had conversations about this dating back 2 or 3 years. Just generally anything about data. Is it reliable? Is it accessible? Is it clean? Who's putting it in? Where do we get it? And are all parties within the ecosystem able to access it in real time? You talked specifically just a second ago about adolescence and the need for that data to be passed along. That certainly is a pulse point within what we heard, but it extends to all places and all people up and down the system, whether it's in schools, whether it's law enforcement, whether it's persons on the bench and the people who support them, whether it's care providers who are right there at the front line. Data. Second is accountability. This was more, we heard this phrase said over and over and over and over again, and it did not matter how long somebody had been working in mental health. They asked this question both rhetorically, but not. Who's in charge of mental health for the state of Georgia? And these were people who are daily governmental practitioners in all of those agencies that Jonky showed you multiple times. I cannot exaggerate the number of times that question was asked of leadership. And they said, who at the end of the day is holding the ball for mental health? And the answer, of course, is both the collective, we all are, but at the end of the day, there is the element within a linear organization like government that the buck does stop somewhere. And so that's what that accountability pillar means. What they told us is we would like to know who's holding the ball for this. And it's okay if we're matrix and we have a lot of people doing overlapping things, but at the end of the day, who's saying this, who's not saying that? The third pillar was organization. And here's what they specifically came back to us and said on that. This was both rewarding and kind of, we understand. The rewarding sense is you have so many people in state government who want to be a part of the solution that it's palpable when you speak with them. They really care about what they're doing, but they think that maybe some of the solutions, which are terrific, we may not be organized as a state government to do everything that we can do effectively based on how the commission is advancing great things within this space. That is to say, are the way our agency is structured, are the agencies that we have, are the way that the organizational charts actually look, are the positions we have the right ones for today, and more importantly, the right ones for tomorrow? Are they the right ones to do all of the things the commission has set out and the legislature has approved and the governor has signed and you all have funded? Are the agencies organized the right way? And the answer may be yes, and the answer may be partly, and the answer may be no. This also includes the assets that agencies have at their disposal, technological systems, et cetera. Are they able to do their job, and are they organized in the right way? And then the last pillar, and again, these are in no particular order, partnerships. The sense was if we do everything that is in the legislation and the commission, and there's general support for it from them, it's how are we working with our partners up and down, side to side in the ecosystem. And that word was meant as holistic as you can make that word. So that's other governmental partners. So it's across coordinate branches of government, but it's also, up and down the stream of federalism. So federal partners and local partners as well, particularly local partners from the state down. And then, and I would extend that to school boards, sheriff's offices, et cetera. And then all other partners. So some you've heard from, some are on the commission, advocacy groups, whatever they may be. How are we working with them to ensure the long-term success? So, Mr. Chairman, I won't go any further. Happy to answer any questions, but the headline here is we're very happy to put together the report. The reason we didn't go over the recommendations, you've already talked about them. They made them into the legislation, which we are so thrilled to have been just a minor part of supporting so much hard work, but didn't want to not leave you with what we heard from all of those conversations for people who are really excited and spun up in the best sense of the word to do good on this. And as you as subcommittee chairs think about your work, these are the feedback points we heard, and we are happy to interact with you at any point in any way you'd like to. Mr. Chairman, thank you.
Thank you. I'm sure there'll be a few questions, but one of the things that might be helpful, and I've had a copy of it before, but if you could just resend us a copy of that report, we'll send it out to all of our members.
Yeah, absolutely.
Representative Oliver.
I can only think about issues in the most concrete way. In the weeds, that's a bad and a good, but I'll ask this question for the benefit of the group. This 30 to 60 children that are in hotels today that are in the state custody, are they new to the state custody system? Do we know anything about their mental health system? Have they fallen through treatment models? And is there any way to know geographically if that matters to how they got to a hotel in Metro Atlanta? In relation to the match committee children and the interagency team children, similarly, where do they come from? What's been this history of treatment failure? Do we know anything about their treatment history? And what is the geographic distribution? When you say data sharing, that's what I think of. I don't think about the broad trends. And I'm trying to figure out if we can solve these concrete problems with our data. So somebody out there in the next.
I think the answer, Representative, is it could be both, right? And so on the micro level of a patient who, yeah, absolutely. How is that patient's case file? How is that data populated so that everybody who can see it, so that if they come before Judge Amero's court and didn't know anything else about it, there would be a flag that he could do a diversion with that person to an appropriate treatment. That if they come into a hospital in Savannah, but they're really living in Macon, they're from Macon, that something follows them. That's what I hear you talking about, right? So that's one issue that that certainly there are systems out there that could do those kinds of things. There's the macro data system that we're talking about that also allows you to make better decisions, right? Are there zip codes that have a stronger negative social determinant of health, whatever that might be on the specific thing, knowing that we can point to data and say, here's the following things that happen in this zip code. And because of this, there's a 900% increase in involuntary, you get where I'm making up numbers right here, but I think both of them exist and both of them can be done. The granular at the patient level and the macro, that allows you to discern trends as a commission to make more informed policy decisions.
Just one other comment, Mr. Chair, if I may. The data issues that came up throughout many of our discussions got most problematical when it got to the point of sharing mental health data history with law enforcement. That's an issue that I don't think we have any resolution of it.
And to follow up on that, at the granular level, one of the challenges that we heard too is just you've got someone in DFACS care, they're on state health insurance, and that foster family or the DFACS worker is not able to access that information to make good decisions, or maybe they've received care from DBHDD. They can't access that information because of HIPAA concerns and other things. So it's one of the goals of 2022 is to really examine that and bring back solutions of how that can be resolved, because I think it's going to be very challenging for us to be able to provide the type of service that we want to provide as a state if we're not able to share the information that we need to share among the agencies that are tasked with doing these individual duties, and it becomes a siloing effect. And I think that's what we're seeing. And there's nothing, I don't think there's anyone that's just like you heard, that everyone cares and wants to do a good job. It's just they feel like they're not able to share the data, and that's an issue we've got to resolve. Any other questions from members of the commission on the Accenture report? And and I'll go to the Zoom here. Let's see. This one. Do we have any members on Zoom that have a question about the Accenture report? We'll also get a copy of that sent out to all the members.
It's a beautiful report. And I think it tells us what we already know.
Agreed. And what we've heard over the last 2.5 years, commission meetings and subcommittee meetings. All right, let me get back to I'm having to go back and forth between Zoom and, all right, what number? Go ahead, Judge Mero.
I just wanted to make a quick comment. It's not about the report so much as some of the unresolved problems that we have going forward. Recently, I signed an order for competency restoration of an individual, and then asked for an update from the defense attorney, from the prosecutor, as to what was happening with this person, because I'd signed the order more than 30 days prior to the time they came back into court for a status update. We were informed by the department that there is a 10-month delay in getting an evaluation completed on this person. So this person languishes in the local jail for 10 months until they are seen and evaluated for the purposes of restoring them the competency to begin to participate in the criminal justice system. So while this is an individual tragedy, in addition to that, you can see in it an opportunity for diversion. This is the type of work that we have to focus on. What are the alternatives to going through a lengthy process like this? So I just want to say that there's a lot of people with severe and persistent mental illness in local jails still, notwithstanding the excellent work that's being done by Chairman Tanner and the commission and all of our partners. But this is a real serious personal problem happening every day. So let's be vigilant. Let's keep this fight going. Thank you.
Thank you, Judge Amaro. Go ahead, Mr. McGivney.
Thank you for the report. One thing I find fascinating is two things really. That all the state agencies you talked to were committed and really had a heart for trying to be part of the solution. The other is them saying, who's responsible for mental health? I think that was the genesis of the creation of the commission in the first place, is who's responsible? Who answers the question that Judge Amaro is asking? So we're talking about coordinating of care, continuity of care. Maybe we need to be talking more about continuity of organization. And so that brings me to this question. Will you have a recommendation to the commission about organization?
We could, and I say that not to be flip. One of our recommendations to OHSC back in November when we submitted it was for lack of a better term, was a full organizational, a nuts and bolts organizational assessment, not policy, but organizational structure, org charts, leadership levels, spans and layers, technological support, all of those sorts of things. The point being is if the commission is, and I mean this respectfully, I hope this doesn't sound disrespectful, it's not my intent. If the commission is building a new house, we wouldn't necessarily want to put an alarm system and an HVAC system and gas lines in it that are from the 1980s. And by that, I mean the support network that holds it up, that makes it run, that makes it does its thing, that makes it efficient. And there may be things that come out of that organizational assessment that talk about how agencies are structured. Are there enough? Are there too many? Are there overlapping? I already heard that there are overlapping functionalities among and between agencies that sometimes creates confusion. I think there's always a benefit to sort of clear the deck on those kinds of things. So it wasn't within our purview. We did make that recommendation that should be a long-term thing that this commission thinks about. I believe that was in our report to you, Chairman Tanner. Yeah, that's right. That's right. That'd be something that the commission think long-term about.
Thank you.
Just curious, did you provide to the state, did you provide a recommendation or a proposal on doing that next step for the agencies?
Us personally, yes.
Is that something that would Grant, I'm assuming, would have a copy of that? Okay. We'll see if we can get a copy of that and take a look at it.
Yeah.
All right. Any other questions? I'm going to flip back to Zoom real quick just to make sure that I don't have any questions on Zoom.
I have Mr. Chairman, I have a response, if I might.
Yes, Justice Boggs.
So to Dr. McGivney's question and the question asked by my friend Representative Oliver, and that the issue highlighted by Accenture about an org chart and about answering the question of who is responsible in Georgia for mental health issues. I think the questions all presume that the answer should be one entity, and they fail to take into account different branches of government, and that the answer to the question of who's responsible is largely going to be dependent on where that individual is in the system, whether it's in the education system, whether in the criminal justice system, whether in the healthcare systems. And so I think we have to get past this idea that the answer to the question is that we ought have, with a proper organizational chart, one entity that is in charge of all of it, because I'm not confident that that sort of system in any organizational sort of reshaping would be practical or even effective. But I get the question because I understand regularly that people in all of those varied systems are always looking for answers, and all they really want is an answer, and they just don't know who to turn to give them that answer. And so very respectful of those concerns, and likewise respectful of Madam Chairwoman Oliver's concerns about siloed data. I am interested in better data because ultimately in my line of work and in work that Judge Amaro and Judge Weaver and Judge Gosselin and other members of the judiciary that are on our committee face daily, is that they make better decisions when they have better information. And so you all should know that the issue of formalized definitions and universal screening and data sharing has been tasked to my subcommittee. And I'm looking forward to talking to all of you about some paths forward about how we might get better data. So that's all I wanted to share, Mr. Chairman, but thank you for the opportunity.
And Mr. Chairman, if I can, good to see you, Your Honor. I think Justice Boggs hit the nail on the head with that simple line of what we heard was people are looking for somewhere to turn for an answer, and they just didn't always feel like they knew where that was. Now, that could come for 1,000 different reasons, but we're just relaying what we heard in those multiple interviews that we did.
And I think that's one of the things Representative Oliver talked about match. You know, in the past, many years ago, and I know Gary McGivney was involved in match years ago, and he could speak to this, but you had that organization where all of these agencies got together and they had a specific issue, this hoteling issue. We've got these 30 kids that are in hotels in Atlanta. It's not the right place for them. We're going to get together and we're going to collaborate. We're going to talk and we're going to put our collective agency heads together. When we walk out of this room, we're going to have a solution to the problem. Then we're going to move on to another problem. And I think that's what somehow we've got to get to, because I agree with Justice Boggs. If the person's in the court system, Judge Amero is reliant, he's relying on the department to do his evaluation. So his court process can't move forward if somebody else is not able to move their process forward. But being able to find ways to collaborate, I think is important. And I know Representative Oliver is very interested in maybe perfecting the match conversation more than we did in House Bill 1013, but all very good points. Eric, you have a question?
No, I don't. I think you hit the point, you hit the nail on the head with the match. That's what we brought up multiple times in multiple discussions. And I think that that's one way to solve the problem.
All right. Any other questions or comments? If not, we will move on to our next speaker. Thank you very much for being here.
Thank you, Mr. Chairman, members.
And we'll get a copy of that report out to everyone electronically. All right. All right, good. I think I've got you back in line here. Georgia Data Analytics Center presentation. Candy, can you pronounce your last name for me?
Kanti Chalasani. Good
Good.
afternoon, everybody.
Very nice to have you here.
Chairman Tanner. And
Thank you.
It's an honor to meet the commission and members of the commission here. Thanks to Grant Thomas and Office of Planning and Budget and Office of Strategy for having me here.
They'll get you set up there. We'll pause for just a second. While they're getting that presentation ready, I'll mention to you that I'd had a conversation with OPB, with Kelly Farr, and with Grant about what the Georgia Data Analytics Center does and its capabilities, because there was some legislation that did not pass this session that dealt with this organization and how that could help with the sharing of data between agencies and how that had been used in some other states. So I wanted them to come talk about what they were, what they did, maybe something, and then we could think through some ideas for our goals of 2022 dealing with data sharing and how this Georgia Data Analytics Center may help. There was some legislation introduced in the Senate around this, so we'll want to take a look at that legislation. No reason to reinvent some of the work. This is good work that's already been done, but we can build on that, I think. So we'll pause for them to get their presentation ready, and then we'll hear from them.
everyone for your patience here. Thank you, Chairman Tanner, for the introduction about Georgia Data Analytics Center. In 2019, House Bill 197 formed Georgia Data Analytics Center. Gdac was established with the intent to build a centralized data hub to provide data transparency and accountability in Georgia. All the speakers, especially Chris Young, and all the data talk was exciting me in the room as I was listening to all of you guys. The goal is agencies have collected tons of data, vast amounts of data in past few decades, and they were analyzing these data within their agencies. Gdac was formed with the intent of pulling all this data together in a governed data access, with providing governed data access so that standardized data definitions are put in place, a governing body is put in place to make timely data and accurate data available for policymakers and legislators to make their decisions. So our goal is to work with agencies, assemble the data together, standardize the data, aggregate and anonymize this data so that we are respecting the data security and integrity of the data. To provide this oversight for Gdac, we formed a data governance organization with many focus groups and committees. We have advisory group that constantly in Office of Planning and Budget that constantly guides us on the goals and objectives of the governor and for the entire state, so that Gdac is focused on the right data sets, especially healthcare data set is where our focus is right now. We have a data management steering committee and business stewards group, data stewards group. Each of these groups has a focus track. The data submission group defines data inventory at each agency, what data elements are available, what are the timings when these data are collected, how to validate this data and how to connect this data together. The data literacy group helps us with the business glossary and defining the calculations, formulas, and policies around the data itself. The data access group is the most important group in this data governance, which helps us with establishing data use agreements. They take long time with some agencies, but data sharing agreements is where this data access group helps us with. They also work on various workflows on when a data request comes from a legislative request. These are the steps that we need to go through. When a media request comes, this is the step that we need to go through, and this is how it goes through a review and approval process before it's released. So we are putting all the checks and balances in place to make sure as Gdac operates to pull the data together from several state agencies, we are also putting the guardrails around this data use and access. We have done a lot of work, especially fiscal year 2022 was a big year for us. We formed, I'm going to skip 2 slides here just to show the amount of work that we did in FY22. We built a modern data architecture, vast amount of data needed, vast amount of compute and unlimited capacity. Cloud was the obvious choice for us. We went and built a secure government cloud, which has all the HIPAA guardrails and policies in place. Just past week, we had one person connect to a VPN, which was showing in a geography which was outside US soil. We caught it within minutes and I got a phone call saying what happened here. We were testing it, how it's going to react, but it got caught. So that's the level of security. We have built this cloud in 3 months, July through October timeframe, 4 months, and we transitioned it to Georgia Technology Authority, where their information security office is constantly monitoring these alerts and alarms to keep our data secure. While all that infrastructure work was done, we were working with several agencies to establish data use agreements. Some of the data use agreements were very fast because we have high level executive support, and we were able to move forward and come to the same page on also define what agency is responsible for and what Gdac is responsible for, and form these data agreements. Whereas other agencies, we are still struggling to make past the first step of MOUs. We have a modern architecture for data ingestion. We built in repeatable processes where time from data collection to consumption is extremely fast, and it's an assembly line that we have put together. As a data set comes to us, we are trying to build a t-shirt model, small, medium, large, extra large, so that we go anywhere from 3 weeks to 3 months before we can take a data set and generate insights out of it. In last FY21, for the work that we did at Gdac, we were recognized nationally by a leading media outlet, State Scoop, for state IT innovation for year 2022. So Gdac won that award for the state with the work that we have done. We have built several dashboards, which I will go into in a minute, and we have published them at an aggregate level for easier consumption and understanding on our website. We are working on new data set. We are working with Department of Revenue for their tax credit data and individual tax return information. We are working with DCH on several state health benefit plan data, enrollment, pharmacy, professional services, overall hospital costs, and additional details. And within a month, we should be releasing some of these DCH data on our website. We are also working with Department of Human Services and DFACS to build a foster care population dashboard. I met with Commissioner Bros and went over the dashboards that we have in place. She asked me about 15 questions. Within 2 clicks, I was able to answer every question that she asked, and I was super excited that we were able to put data in a format where we are allowing her to do her job effectively. Ultimately, the goal set forth by our director, Kelly Farr, for us is put technology at the forefront so that we are allowing efficient operations in state of Georgia. That's the ultimate goal with data. I meet with him on a weekly basis, so my goals and objectives are very clear-cut defined by him. In the interest of time and all the work that you're going to do, I'm going to jump into demo and stop talking here. I just want to mention one topic, Chairman Tanner, as you touched on data use agreements. It's the biggest barrier for us right now. If anything, I really respect the work that you all are doing to help us reduce some of those barriers. The faster we get access to the data, the faster we can secure and make timely and readily data available back to you. With that said, I'm going to go to the Gdac website first. Gdac.georgia.gov is our website where we have published some of the aggregated data from several data agencies that we collected. Building and lease inventory, property, the revenue collections, QBE, quality basic education, funding information, the state operational information, revenues, expenditures, and state agency payroll, vendor expense information. So there's a lot of tons of, because you can access these dashboards already, I'm not going to touch on them. I'm going to touch on the dashboards that we are about to release soon out. So this is state health benefit plan dashboard, where we are trying to make sure monthly we will be updating these data. So the data every month as the data are updated, our Gdac website will keep updating these dashboards. So if I were to pick any county, let me go to Dawson County. At the county level, we can see how many state health benefit members are enrolled at Dawson County. And then we can also look at different types of healthcare plans that they are enrolled in, and look at employee status of these. What are the different types of employees there are? So I'm just going to click on teachers here, so we can see that majority of the state health benefit plan members from this county are teachers. So this is just one example of the DCH data dashboard. I'm going to touch on another dashboard that will be released soon, is the pharmacy data, where we can see the costs of different drugs, the generic and the product name, and how much it's costing overall by year and by month. So as you can see, this total claims for the pharmacy and the prescription counts and the cost for the prescription. We can look at by generic name, and even let me just filter down to one popular Tylenol that everybody uses, acetaminophen, to show you the cost just with that one drug. So we are trying to build dashboards for diagnosis and prescriptions. I heard Representative Oliver ask questions about hoteling data. We did do a dashboard on it, which was giving all the information in clicks away right now because it's a very sensitive data set. I cannot demo here, but I have Commissioner Prose has reviewed that and she's very much excited. We are trying to build suppression rules around that so that when we release, we are respecting the privacy of the population that's involved in there. So this is just an example of one generic name and total claims for Tylenol or hydrocodone here, and the cost, the number of prescriptions written, overall cost for these prescriptions, and cost for prescriptions. So this is just an example. This is just a drop in the ocean of the work that we are doing. We have built a modern technology that can take the data from all the agencies and produce the insight and make the data available to support the key pillars that Chris mentioned: data accountability, organization, and the partnership in the previous presentation. I think Gdac is ready to do the work. Really, thank you for your time.
Let me, the legislation, there was some legislation introduced last year, if I understand it correctly, and I've not reviewed it specifically in detail, but it would make the Georgia Data Analytics Center a sub-agency of other state agencies. Is that correct?
That's very correct.
Which would, in theory, get around some of the concerns about data sharing between agencies, since your department would be a sub-agency of everybody.
Yes, that was the step towards the right direction, I think.
And if and you may not know the answer to this, but it's my understanding, I think some other states have done something similar to that. Is that right?
It is right. I had been to a summit, national summit recently, and I met with North Carolina team that was doing exactly the same stuff, and they have a huge success there.
Okay. I think it's important as we move forward. I think this is a good start in the right direction for helping with the data sharing problem. And again, I think there was a piece of legislation that was introduced that went a long way toward accomplishing that we need to take a serious look at and consider that as part of the commission's work. this commission's work around this area carries with it a certain level of, I think, influence at this point if we're recommending as part of a broader piece of legislation. So, and I also want to say to you, I've had several conversations with OPB Director Kelly Farr. He speaks very highly of you and the work you're doing there. So award-winning work, it sounds like. So thank you. Thank you for what you do. Are there any other questions about the Data Analytics Center, what they do, what they're capable of from the members present? And then I'll switch over to Zoom. Number 8. Yes, ma'am, Ms. Levi.
Yes, I have a question. So what is the composition of your organization?
We are a very small team, but the way we work is very smart. I did put it in there in case we had a question. Right now that's our size of the group here. We are 6 people, and the way we are working is we have vendors for analytics, we have vendors for infrastructure, and GTA provides us some infrastructure currently. So we are working in a parallel manner with a small team.
Okay, and what is the background and experience of the team?
So we are all data professionals. I have been with state of Georgia for 25 years. This is my 5th data warehouse in the state, and I live and breathe data. And so are some of my team members, and we are very passionate about what we do, and we are really honored to be part of this team, touching people.
Well, we can hear and see your passion. So thank you for that.
Thank you so much.
And I was wondering, because you made mention of some interactions with the North Carolina team. Did they do any work regarding mental health that you were aware of?
I did not talk about just that one use case with them, but just today I connected with their chief data officer. So I do mean to lean on their shoulder and learn more from them. I will ask that question and get back to you.
Okay, so are the agencies inputting the data and then you are then taking it? What are you doing with it then?
So the way it works is we have built a cloud secure transfer.
Okay.
Agencies just drop the files there. We have an automated pipeline built. First time we learn about the data and we customize the pipeline. Once the pipeline is in place, it just goes from their input location. We connect the dots. Basically, if there is a social security or if there is a low level data coming from one agency, we connect with another data, let's say DCH data and DHS data. We connect the 2 dots together, and then we anonymize the data. After the data are anonymized, we obfuscate all the PII. Basically, nobody's date of birth, social security, or anything is there in our analytics layer. It's completely de-identified data. We take that de-identified data and then we aggregate it. Once that data is ready, we build the analytics and report out. We are also building these data sets, and our data governance committee will define how we can release these data as public data sets out so that researchers have secure data available for their independent research. It's not just us trying to tell stories. We want to give this data to people who are real public entities who are wanting to serve their constituents, constituents. They can take that data and build their own focused analytics. So our goal is to make this public data, build a Georgia data capital and serve this data in a secure manner. That's the ultimate goal, and cannot wait to get there.
Okay, so de-identified data is important, but if you heard earlier, one of the things that we've been challenged with is if we have an individual that is a friendly face that is receiving services from multiple entities, we need those different touch points to know what's going on with that individual. So have you been challenged with anything similar to that?
So with the hoteling dashboard, we took that data and we were trying to connect the dots. We did not release it, but in a secured way, we were able to paint the picture on what allegations are most frequent for that population, what diagnosis is at the peak, and what medications they are on, and how many times this population are placed. They are thrown back and forth between different, it's just sad to see that, but we were able to make the patterns and learn about them.
Good.
Once we have the all policies and procedures in place, we will be at more liberty to talk and disclose those.
Thank you.
Thank you.
You know, I bet Justice Boggs and Dr. Serbin that's on Zoom are very, very excited to hear you talk, because they are data-driven individuals. And let me switch over. Does anybody else have a question here in person? I'm gonna switch over to Zoom real quick. Takes just a sec. All right. Anyone on our Zoom call have a question?
Yeah, you're right, Mr. Chairman. I'm going to provide Gdac an office in our building.
Thank you. Thank you so much.
I do have a question. You know, obviously your work among agencies within the executive and legislative branches is impressive and can be somewhat illuminating and helpful to the judicial branch, in as much as your work, if you've done any with the Department of Community Supervision or State Board of Pardons and Paroles, and any other number of state agencies. I am wondering and curious as to whether your Gdac has done any work for the judicial branch across the state.
We are working on our first use case with one of the judicial branch, but corrections, yes, we have a data use agreement with Department of Corrections, and we have also ingested their data in.
Do you have a data use agreement with the Department of Community Supervision?
Not yet, but we will be happy to with your help.
I'll leave that to Commissioner Nail, but I'm just curious, you know, obviously your work with state agencies is obviously important and impressive. I just, being in the judicial branch and being interested in disaggregating data that is accumulated within the various judicial branch organizations is going to be helpful to my subcommittee. But thank you for all that you and your team are doing.
Our cooking station is ready. Just give us the data.
All right. I like that. You and I are going to get along really well.
I knew I called that one correct, Justice Boggs. We couldn't see you earlier, but I knew you had a smile on your face during that presentation. And I don't think this lady's ever met some data she wasn't interested in, so she's ready.
Okay, good.
Any other comments from Zoom?
Yeah, this is Mark Johnson. Thank you, Mr. Chairman. I'm very interested in the use of claims paid data from Medicaid and state paying, particularly for mental health and substance addiction. I'm aware of a number of states who've been able to use that data to identify and start programs that have actually bent the cost curve on the expenses of those services. And I'm wondering, does the group do anything with claims paid data, do any analysis? I certainly am not aware of any, but I just wonder what's our current state of the state when it comes to using claims paid data for.
Thank you so much for that question. We have been working on that data use agreement for 8 months now, but I think we are close to get the Medicare.
Thank you. Nicoletta, that's a mathematician at Georgia Tech. If you haven't met her, her specialty is healthcare systems. She serves on our workforce system development subcommittee. She'd be a great person for you to meet. One of the things, because she has said this over and over to me, that if I could just get the data, I can create information that will give you outcomes for what you're trying to accomplish, but we just don't have in Georgia access to the data that we need to make informed decisions. And it sounds, I know your group's working hard to change that, and I think we can help with that through some additional legislation. But I think it'd be great for you to connect with her and talk to her. She gave me a copy of her book. She wrote a great book. I did try to read the book.
I think I will.
You would probably really enjoy it, but it's a good book, but it was challenging for.
I'll be on it.
Yes, you'll enjoy it. All right. If there's no other folks on Zoom, I'm going to switch back to our room here, and I know we have one other, at least one other comment here. So give me just a second. All right. What number, Judge Amaro? 12. Judge Amaro.
What interaction do you have with the Criminal Justice Coordinating Council, if any?
Could you repeat that?
What interaction do you have with the Criminal Justice Coordinating Council, if any?
I don't have any yet, but we will be happy to. I think the best way to get these new use cases and agencies on board is on our website. We have created a form for use case request. If someone, it's very easy to fill. We just need an initial contact, and we will follow up with them on what their need is and start putting the whole pipeline together for them. So on our Gdac website, we have a use case request form. Fill as many as you can, and we will contact you guys and work.
Because I've just been made aware of some excellent work done by them and applied research services in identifying predictors of mental illness in county jail data. So thank you for that.
All right. Any other comments? Well, again, thank you very much. And, you mentioned working with DHS, Commissioner Candace. I just want to give a shout out to her because she is doing great work over there. She's my kind of person. She's a disruptor. She's not accepting the status quo, which I think we need more of personally. And I think that's what this commission's doing, is challenging the system and figuring out ways to make the system better. So thank you for your part you're playing in it. And we'll send the message to Kelly Farr. What a great job you did today. So thank you
so much. It's an honor to meet all of you.
Thank you.
Appreciate your time.
All right. Next up is DCH. This is a hard act to follow for you two. So. If you don't mind, when you present, just introduce yourselves to the commission.
Absolutely. Good afternoon, Commission. My name is Kaylee Noggle. I'm the Commissioner of the Department of Community Health. With me today is Joe Hood, one of our senior policy advisors. He's going to move the slides, but I'll start with just a few comments. I've had the opportunity to meet and work with a few of you in a number of different capacities over my career, but this is the first opportunity I've had to present to the Commission. So thank you for that opportunity. As currently structured and designed, the Department of Community Health is really the regulatory, finance, and compliance agency in the healthcare spectrum. We are a very large insurance firm. We act as a broker of services. Our job is to connect our members with the ultimately providers and services to increase access to care and healthy outcomes for Georgians. So we have been working, I'm obviously not the most experienced healthcare professional in the room, I can assure you of that. But I have, I think, brought to the role a healthy use of the word why and some skepticism on how we're doing things and why we're doing them that way. So I hope that you have noticed or have at least heard over the last year, we have really focused on increasing our agency's accountability and transparency and moving things forward and how we execute and get things done. I think we've are working to more fully appreciate and exert our influence in the healthcare spectrum in our role in that delivery. And then it's our job in this bill, HB 1013, to make sure that we meet our requirements laid out in the bill so that we fully implement the intent and effect of what you designed. And so happy to share with you today some updates on those requirements and where we stand in implementation. I've also been involved in a lot of the things that you've already mentioned today, from data sharing agreements to our data that Connie is now using, to the Workforce Commission, to the workforce efforts, to our work with PRTFs and working groups, to the behavioral health, DBHD's interagency directors team that is similar to the match. But happy to speak to any of those things I can. It won't take much to stump me, but I'll do the best that I can. So thank you for the opportunity, and Joe's going to help me along. I'll start with the first requirement. I'm just going to kind of go through, as the chair lady did, kind of summary by summary where we are mentioned and what those requirements are, and kind of give you a standpoint of where we are. I should preface it by saying This was one of the best budget and policy years that the department has seen in many, many years. We are fortunate there was a huge influx into our budget this year. That also means we have a lot of things that we're working on implementing. If you've listened to any of our board meetings over the past few months, we are very expeditiously trying to move things forward through our approval process and up to the federal CMS approval process for those things that require it, so that we can make sure that effective dates align with other requirements. So Section 1-3 moves the patient's right to independent review program from DCH to the Department of the Office of the Insurance Commissioner, and I'm sure he can speak to that as well. I think he's here, but those efforts are underway. Our teams are working as previously housed in our Office of Health Planning, and they are working consistently coordinating on that move. Our website now lists the contact information of where applicants, applications and renewal applications to be those independent review organizations now need to be sent at the Office of the Insurance Commissioner. Section 1-4 is a big bulk of it, requires all state health plans to meet standards of federal mental health parity and the Addiction Equity Act of 2008. That includes our internal fee-for-service plan and providers, as well as our current 3 CMOs spanning both Georgia Families and Georgia Families 360, which serves our foster care population, as well as our state health benefit plan that we manage. I think they have all been under those requirements to 2008, but I think what this bill does is gives us some additional enforcement and compliance kind of teeth, and we're working and planning on building that component of it so that we can move on to the next sections, which then require that reporting and compliance reviews. By January 1, 2023. I think what you'll find on our website right now is that there are existing CMO parity compliance reports that are posted periodically. Those have been on our website for a while and they are there. We are open to feedback if that's the level of detail that the commission wants to see in those reports, or if there are additional things. We are working with the third-party administrators, Blue Cross, United, Kaiser, the TPAs under SHPP to develop a similar set of reporting and metrics for parity compliance. It also requires DCH to complete a parity compliance review annually. We have a number of vendors that work with us on contract management, and we've worked very steadfastly over the last year to increase our abilities in contract management, and that will be something you see and hear us talk about a lot over the next couple of years. And many of you probably know we're currently in an RFI period as we progress towards an ultimate re-procurement for our managed care organizations. And a big piece of that will be our internal capabilities to manage those contracts effectively, both from a general management perspective, but also putting in the right metrics, the right service language agreements and things like that, so that we are ensuring that we get what we intended to when we go out to bid for these things. So that'll be something that's on us to make sure that we're and communicating with you what those resources need to look like at the department in order to effectively manage that. But some of that work around parity compliance will be baked into some of those other contract management activities, and you'll see some reports there as well. Continuing into Section 1-4, which requires the establishment of mental health parity violation and complaint process and a repository for tracking those complaints by July 1, 2023, and then requires us to report, to submit that information to Conti and her team at Gdac. We are underway with that. We're starting to do some preliminary system updates with we have a major third-party vendor that processes all of our fee-for-service Medicaid claims, and starting to update at least the minimum amount that we need to do to start being able to track, so that when someone calls, that they can accept that call and record it as being a mental health parity complaint or violation, so that we can at least start to track those things. We'll continue to have conversations about that. Website developments will obviously have a place on our website where that's pretty plain language for folks to be directed to or to submit a complaint. Our CMOs are, which we have regular monthly and bi-monthly meetings with, are developing those same processes as well. There is a working group that's defining those processes and the related reports that need to go along with those, so that work is underway. Chair Lady mentioned the minimum medical loss ratio previously for CMOs. Federal guidance suggests a minimum of 85%. In fact, over the past 2 or 3 years, we've had that in place. It was actually a little bit higher. We implemented what was called a 2-sided risk corridor during COVID to guard against both upside and downside loss for the CMOs. We're in a draft rate setting period with our CMOs right now for the rates for FY23, and it includes a minimum MLR of 86%. So that will be 2-sided risk corridors are a little bit of an anomaly. They were allowed federally during COVID because of the unknown utilization during that time period. But as we transition away from the two-sided and move to a minimum MLR, we're setting that at 86 right now. And so there's, if you're interested in the two-sided risk corridor or what that was, happy to explain it to you. It's a little more complex than just the minimum. It had an upper limit as well. Those are in draft right now. We are continuing to have conversations with the CMOs, but those will be submitted to, those rates get approved and contracts get approved by CMS. And so those will be sent up with an effective date of July 1. Section 6-1 requires the completion of several studies by December 31st. Several of those are what we call rate studies, which will look at reimbursement rates paid to mental health service providers in comparison to other states or plans, costs relating to treating uninsured patients in EDs or emergency departments while they're waiting transfer to a behavioral health facility, an analysis of all mental health funding distributed to statewide by various agencies, medical necessity denials for adolescent mental and behavioral health services, and a study related to coordinated healthcare for foster youth, including data sharing. So we are drafting that scope of work and what that would look like. DBHDD was also charged in the budget and this bill with doing several rate studies as well. We'll likely combine those so that we have one actuarial firm doing rate studies on all of those things collectively. So we've got the same set of mathematicians and data scientists doing that work for us. And so don't anticipate that that will be a problem to get those completed. And then section 6.5 defines coverage requirements for drugs used to prevent and treat mood disorders with psychotic symptoms. Our prior authorization requirements are being updated and will be in place by July 1. Those are posted online for all of our prescription drug coverages. And I've listed that website there where you can find those for Medicaid, and that the plans will follow that as well. Some of the other items in the bill that we're not the lead agency on, but that we'll certainly participate in. Obviously, the Office of Health Strategy and Coordination has been mentioned a couple of times, and their creation of a recommended unified drug formulary for both Medicaid/Peach Care and SHPP separately. We've certainly begun to share with them a lot of information on how those processes work now, what our Drug Utilization Review Board currently does, how the CMOs and their PBMs operate, how any changes that might impact budget or costs related to drugs on either side of the house, the fee-for-service, Medicaid, or SHPP, but are certainly having ongoing conversations with them and are happy to provide information that they need to do their work, as well as the transportation study. Specifically, NEMT or non-emergency medical transportation is where we would come into play in that conversation. We'll obviously share information with them. We have an active RFP open right now under NEMT, and so happy to talk with them about that and what that looks like. Obviously, with DHS is charged in the bill, the interagency data sharing system. Commissioner Rose and I have had conversations. She and I both started in these roles about the same time, a couple of months apart, and just even chatted this week on the system I think that she is trying to build specific to her foster youth population to get a direct feed from our system so that while Conti's data is more analytics and reporting after the fact, that she can start to build for her caseworkers and case managers more of a real-time repository of all the information available about those youth. So coming from our side on medical claims, feeding back to them, then making it available. So we're working on some things like that. And then within DBHDD, the multi-agency treatment for children of the match team will certainly play a role, and happy to participate in that. This is a lot of work. I've gone through it really quickly. It's a lot of work, and I'm very proud of the team, but very thankful for the opportunity to do it. Like I said, this has been one of the best policy and budget years for our department and the work and the scope of our responsibility. So thank you for the opportunity to work with you on it, and happy to attempt to answer any questions that the commission may have.
Thank you, Commissioner, and thank you for all you're doing. We're excited how responsive all the agencies, and especially your agencies, been to the commission and getting started and meeting these deadlines so we can move policy forward. So it's very helpful. Thank you. Representative Oliver.
I'm very interested in your rate study. And here's my specific question. Hypothetically, if Georgia pays $408 per day for an intensive psychiatric bed and Tennessee pays $600 plus for an intensive psychiatric bed for children specifically, doesn't your rate currently invite other children in other states to send their children and take our Georgia beds?
Oh, I mean, there's a lot of economics at play with that for sure. I think, Gwen and I have had this conversation at her facility, in fact, and with others, and I'm scheduled to go see some others. There's competing economics there. I mean, as a state and as a provider, we certainly have an interest to reserve those beds. But they obviously have a duty to their organization to fill the beds as well. Certainly, I recognize that, I think we did what we could within the budget that we had this year and provided a rate increase to the PRTFs, and we're thankful for the feedback.
There's a 10% increase that if Tennessee stayed at about 600 and you went to 440.
Sure. There's still a big gap there.
Is it true, or do you know, I don't know exactly, but over half the intensive psychiatric beds in Georgia are filled with children from other states?
I don't have a current count. We don't get that information regularly, but we did have a PRTF working group that's met over the last 12 to 18 months. And I think that's probably a fair representation.
This is a question I'll ask again when your rate study comes in. And I just want you to know it's a pretty high priority in my mind.
Sure.
Maybe I'm only speaking for myself right now.
No, absolutely. And I think we're happy to, I think we'll follow your lead on that. I mean, we're going to complete the rate study and it will bear what it bears. And then it'll be a conversation of all of us then what to do with that information. And I'm happy to take that in a certain way. If there's specific things you want us to look at that.
Could correct me because I'm a little confused right now. Do you set a new rate?
No,
or
ma'am.
does the governor set a new rate, or does the budget committee set a new rate, or does Kelly Farr set a new rate?
So we could certainly make a recommendation and we'll share the report, but we would have to receive some funding to do it.
But it starts with you.
Potentially.
But that's what I just want to be clear about that in terms of what our organizational chart says.
This
It
rate
starts
study
with you.
will show that. I think then it will, because there are a number of different providers that will look at it, will give us a range of options to look at perhaps where we need to target those rates first, if it is the PRTF beds or the intensive psych beds, but we'll certainly play an active role in that with you.
I thought it started with you. And I'll be following up on that and see how it goes, because I'm pretty interested.
Sure.
Thank you.
Just to follow up. So it's once the rate study's back, that will start guiding your policy recommendations internally at DCH, I'm assuming. And then as a result of that, that's going to drive the governor's, what he decides to do in a budget proposal to the General Assembly, et cetera. But this is a starting point to making improvements in that area.
Absolutely. Absolutely. We'll work with Grant and his team at OHSC to see what there are and share that info, share the rate studies as soon as we get them finished.
And I think that it's an important thing too, is we'll have the facts, right? I mean, there's always talk, and we've talked on the commission level about what ours is versus what someone else's is. It's going to be helpful to have the data set so that then we can argue about here's where we need to be to get in line and to stop the other states from taking our beds. Dr. Fitzgerald.
The number that we just quoted was from a snapshot. We asked the facilities to provide us with that information. Clearly, you guys know how many beds there are. And is there any way that you can fairly simply put into your data looking, how many beds are we paying for right now? And the difference would be somebody else is paying for the other beds. Is my question clear?
Yes, I think your question is clear. I think it's possible. I think it's nuanced, and when you might be able to help me, but it's not just in-state or out-of-state. It's also, is it Medicaid or is there a private payer in that bed as well, which could be still be an in-state youth, but with a private pay.
We understand that.
Yeah.
There's a lot at play here. And I want to say to you first, thank you, because we haven't had a forum where we could publicly thank you. It had been 8 or 10 years since your psychiatric residential treatment facilities had experienced an increase. So we were in pain, and we all acknowledge we're not where we need to be. We still have work to do. But what you did to me was a very bold step. And you did that very quickly, and it helped relieve some of the immediate pain that we had. We need to know too, We do, right? It's true because the PRTFs talk to each other and we put our data together and we know how many beds are filled with kids from out of state. But there's also the issue that we send children out of state. So while other states are using our beds, we're using their beds. So it's really a national issue. And you only have to look in the news to read that all the states are struggling. And it's so important to have the data to know what kind of beds do we need, which is the conversation that Representative Oliver and I were having. A bed is not a bed. You can't just say we need 500 PRTF beds. It's all about the kids that are in those beds and what their treatment needs are. And there's some specializations that we don't currently have in our state, which are causing us to send kids out of state that we need to develop. And then whenever you look at the rate in residential treatment facilities that have an educational program, you can't just say California pays this rate. You also have to say, what do they pay in education? Because Georgia pays us education dollars. So you have to balance those two things and look at those collectively. So just some thoughts, but I didn't want it to go without saying thank you for the step that you took to help us. And there's still work to be done, but we knew that.
Thank you for that.
And I echo that. I think it's a great move, and we didn't get in the place we were overnight. So it's going to take some time to continue to improve, but it's a great step in the right direction. So thank you. Ms. Levi.
Great. Thank you. Commissioner, as you know, there is a workforce shortage. And so when we look at the provision of mental health services in the state and look at the fact that we are having a rate study, I have to ask the question, so when you look at a rate study, is there going to be a projection of what we need to pay in order to be able to employ professionals to do this work? Because if we just look at what we are doing currently, all of us are struggling with having to reduce our census in every level of care because we cannot get the workforce.
Sure, and I think it's a bigger, broader conversation with workforce. It's a very macro level issue. I think one that we're going to tackle over the next few months. The governor, as I'm sure the commission well knows, has created a healthcare workforce commission that I'll be a part of, that many different sectors of the healthcare industry will have representation on. And it's one of those things I think we have to look at to figure out, where are we today? Where do we need to get in terms of a workforce? And then what's the gap and how do we fill the gap? Is it rates? Is it the educational pipeline and how we recruit students in, and the expediency with which we put them through to actual on the job bedside workforce? And so I don't know that there's one single thing that's going to fix it. It may not just be rates. I think rates are part of it, but I think it's a holistic conversation, and I'm excited about the rest of this conversation that's coming in order for us to hopefully build a better picture.
Okay, thank you. I just wanted to make sure that consideration would be given to the fact that we can't hire staff or retain staff because of the rates.
Sure.
Thank you.
Thank you. Any other questions from members present here? All right, I'm going to switch over. Give me just a second. All right, anyone on Zoom have a comment or a question? All right, if not, then I want to thank you for being here today. Thank you for what you're doing. We're looking forward to seeing these reports and continuing to work in partnership.
Thank you so much.
Thank you. All right, good. Thank you very much. Next, we have Insurance Commissioner John King is with us. I want to thank him. We had several meetings with his staff and with Commissioner King during the House Bill 1013 after it was introduced. As you know, parity is the #1 issue that in this bill. It's called the Georgia Parity Act, and that would not have been possible without the work in partnership with the Insurance Commissioner's Office. So Commissioner King, thank you for that, and we'll turn it over to you.
Thank you very much, Mr. Chairman. I have with me Greg Conley, one of our top team members working this very difficult and tough issue with me, so he can help me with especially some of the questions you may ask. You know, how did I come to this? You know, I started my professional career as an Atlanta police officer, walking a footbeat on Auburn Avenue at night, walking Coretta Scott King to her car every night. And so I saw as an Atlanta police officer what the failures that we had in our communities. And then I went to work on Beaufort Highway as a Doraville police officer, and then became chief of police. And I will tell you, and if you talk to any sheriff, any police chief in Georgia, probably in the nation, one of the main challenges that we have is, you know, I'm willing to guess that the majority of the bad encounters between law enforcement and the citizens, there's going to be a mental health or a drug addiction component somewhere in there. And so as I, you know, being a member of the Georgia Association of Chiefs of Police, talking to my fellow chiefs and sheriffs, this is important. This is important to me. So when I got asked for our agency to be part of this process, I jumped with both feet, and there was no hesitation. I had several great conversations with y'all. Of course, I've been a National Guardsman now. I'm on my 40th year. And so I've served with a number of combat veterans who are walking and trying to, you know, dealing with the, you know, with obviously the legacy of serving in combat. And so I know where this problem sits. So I'm really proud that Georgia is facing up to the challenge. And so that's why my agency, we're looking at being a good team member with Commissioner Cagle and looking at removing every, you know, bureaucracy, you know, every bureaucratic barrier. I know we don't have a significant task in this, but we're looking to continue to work with this commission and with our other fellow agencies, how to remove barriers so we can get to actually provide the services that Georgia's been sitting, you know, that we're behind the curve. And so I'm really proud of the fact that this commission and the talent associated here, and obviously this is a priority. And when the legislature and the governor's office, you know, spoke with a pretty loud, clear voice, especially in an election year, which is truly unprecedented. I'm proud to be part of this, of the solution. And so I know that our job is to assess with insurance companies and basically issue a report, working closely with our other partners to make sure that we use our authorities. And I've had personally already started having those conversations with insurance companies. Hey, this is coming. This is important to the state of Georgia. You need to get on board. You need to come along and give us the data so we can perform, so we can do our analysis and issue our report of the performance of various insurance companies. And so with that, Mr. Chairman, I wanted to make sure that the commission understood where I'm coming from and why this is important to me. And we're committed to removing any obstacle, bureaucratic or, you know, ego or whatever it takes to get through so we can get some solutions on the road.
Commissioner, and this may be a question for Greg, but Greg worked with us closely with drafting the updated draft to the bill, making sure that what ultimately passed was something that the Insurance Commissioner's Office felt was doable, legal, constitutional, met federal guidelines, et cetera, all the things that we've talked about. Do you feel comfortable where House Bill 1013 landed and comfortable with your office's ability to be able to enforce parity the way it's laid out in House Bill 1013?
I'm comfortable with where we're at. Obviously, the first set of data that we get and that continuing conversation with this committee and with the members of the legislature, we will need to adjust. I know this is the beginning point. And so I clearly understand it. Obviously, we're going to have several iterations and some, you know, but I'm comfortable with the authority that we have in the state of Georgia and to be able to get the data from insurance companies. Obviously, if the data or their experience of the first set of data that doesn't give us what we need, then obviously we will come and revisit and reapproach this problem. I mean, I know this is the beginning. Greg, I don't know if you want to add anything to it.
Yeah, I would say that I thought the final bill was excellent in terms of the powers that it gave us. I really appreciate the fact that you included a data analyst in the in the bill. That was really important because we did not have the staff to do this. This is a pretty serious undertaking, but I think that the enforcement mechanisms are exactly what we need to enforce it. And I think it's an excellent start for us to start diving into the parity analysis for insurers in the state of Georgia.
Well, and for those of us who were working closely with you and Representative Oliver and Kim and Dr. Fitzgerald and others during that conversation, I think our door is open to the commission level. So if you see things that you need tweaked in legislation, we're going to be preparing a report. We're going to be recommending legislation for next year. So if there's things that we need to change, let us know because we want to be helpful.
Mr. Chairman, it's a two-way street, obviously. If there's something that we need to dig in deeper, please, again, I'm committed to removing any obstacles that get us to where we need to be.
Good. Representative Oliver.
Thank you again for your time. I've learned from you and from others in your position that your National Commission of Insurance Commissioners have coordinated some about how to respond to this new federal act that'll help us implement the Georgia Act. Where have they given you any specific, because this is a national enforcement issue, and I'm really interested in whether we could have a national enforcement mechanism.
The challenge, we're wrestling with this across the nation, and I'll let Greg add on to, get me out of trouble if I write a check that I can't cash here. There's a lot of discussion, and a lot of it is about the approach of using a commissioner's regulatory authority. And of course, there's only 13 insurance commissioners in the nation who are elected,
right?
And we're accountable, versus everybody else is appointed by their governors, and of course, I would say that would not as accountable, versus the tension between the federal government and a bureaucrat in Washington, D.C. responding to the calls that you all are getting, who many of you all already have my cell number. And if you don't, you easily get it. I will make sure. And so I'm accountable to you all versus an unknown individual down at the Department of Commerce or Department of Treasury or CMS. And a lot of this, I think I'm more comfortable operating with the authorities that I have here in Georgia as an enforcement mechanism than relying on the federal government to make a decision whether to hold an insurance company
But Anthem
accountable.
is a national group. And if Tennessee's asking Anthem for data on parity, is Georgia asking for the same data? That's kind of what's confusing.
Because we talk routinely with the insurance commission.
Sure. So I think there's a kind of a couple of challenges when you talk a national approach. When we've spoken privately with the other states at the NAIC, we have regulator-only meetings so that the only people who can go in are the representatives from the states. And there is a lot of confusion even at the federal level as to what it is they want.
Intentional confusion?
I don't think it's intentional. I think that our understanding, and I can't speak for CMS, but our understanding is that the Mental Health Parity Act was passed, but it was not really followed up on well from a regulatory perspective. And so that the first states that started to handle mental health parity kind of went to CMS for guidance, like, you guys passed the first rule, what should we do? And they were like, look, we just sort of ask them for this data and see what we get.
That's what I'm worried about.
And that's not how the states operate. None of us do. And so the data, when you do, and I don't want to get too in the weeds on data, but it's very important the form that you ask it in. And so one of the conversations that we've been having amongst the states is, what form is your state using? What form is ours? So we want to get similar data sets. And I think where the direction we're headed is probably a baseline amongst the states. We'll all sort of ask similar questions. Now, getting 50 states to all agree, because we're all on, it's 50 different regulatory schemes, 50 different laws, but I think that we're from a data perspective, from a regulatory perspective, we all kind of want to see the same things. It's just a matter of Tennessee might demand different things than Georgia, getting us all to agree what's a solid baseline to then follow up on, because once you get an initial set, you're like, now we want to start asking real questions of what's going on. So I do think that's the direction that we're headed. I know those conversations are happening, and I think that's where we'd like to get to.
You will see, we tend to have a little bit more consensus in the Southeast United States commissioners. We tend to see the world because our problems are generally related because of the region that we serve in. And so we get a lot more consensus. And what we're being mindful is whatever data that we ask is data that we're going to use, not just asking data for the sake of asking for data that we're not going to use. And so it's important for us to have that ongoing conversation. And we have regular conversations on regulator to regulator forums.
Other questions from anyone here in the room? All right, let me switch over to Zoom. Let's see. Is that right? All right. All right. Anyone on Zoom have a question? All right, good. Kim.
I just want to thank Commissioner King and the staff for all that they did. He was absolutely right, stepped up, had a heart for what we were doing, and we truly, truly appreciate it. It was recognized, and we just thank you.
Well, thank y'all. Y'all built this team of so many different groups. I mean, you have my old friend from Decatur here. That's pretty impressive. So
we learned a long time ago, if you want to get something done, you got to have Representative Oliver in the room.
yes,
Yeah.
she's got a way.
Yeah. You want her for you, not against you.
Yes.
Thank you. All right. Well, Commissioner, thank you. Thank you, Greg, for all y'all do. And we look forward to continuing to work with you.
Yes,
Thank
Mr.
you.
Chairman. Thank you so much. Appreciate y'all.
All right. With that, I just want to make a note that it is a little over 15 minutes early. So finishing the meeting, we like to start on time and finish on time. I do want to thank a couple of people, though. First of all, Miriam's here from NAMI, and she is always happy to help us at the commission. One of the things about this commission, everyone here is busy. We all have other lives and jobs, and we don't have any staff on the commission. So we borrow and steal from other people's staff. And thank you for helping set up today and everything you do. Emily's out there too, the executive director of Resilient Georgia, always willing to help us and we wouldn't be where we are today with House Bill 1013 if it wasn't for her work. And again, always willing to help us. And Chelsea is not here, but Chelsea's my admin. She's a little under the weather, but she is always willing to help too on a volunteer basis. But we're hopeful that we have actually a private funder that has approached us about hopefully funding us a staff person. So we should know that in July. That would be very helpful. If we do that, we'll get that information out to you if that person comes on board, and contact information, especially for our subcommittee chairs as they work. This person would be at your disposal to help. So that's exciting news. Kim, thank you for helping us hopefully get that going. Are there any other comments from anybody in the room about anything before we adjourn? Are there any comments from anybody on Zoom?
I have a question.
Yes.
I am wondering, this is to maybe Representative Oliver, on the match program, have we considered having a multi-agency for adults as well as children?
I know that's an issue, but I don't think we specifically talked about it in terms of 1013. Let's see how successful we might be with our children's match effort and take that under consideration.
Right. I just know I have a lot of mental health people that are basically living in regular hospitals with no placement.
Yeah, very good point. Thank you. Any other comments or thoughts? Well, again, I want to thank our speaker and the governor and all the leadership from Mary Margaret Oliver and Todd Jones and all the others who worked on this bill to get it to a 100% passage rate in both the House and the Senate. It's a great start, but it's going to be the decade of mental health reforms. We've got a lot of work to do. Your subcommittee chairs are going to go to work. You're going to be getting notices. I encourage you to stay involved, give your input. Subcommittee chairs drive this conversation. So we're excited about what this year holds and look forward to coming back as a group with some strong recommendations. Everyone, do we have a motion to adjourn?
So moved.
Do I have a second? Motion and second to adjourn. All in favor, aye. Any opposed? We are adjourned.